Okay, hello everyone. Today we will learn a new topic, anemia. It is a very easy but very important topic to know each and every general practitioner and each and every doctor about the anemia. Today we will deal with the anemia, what are the causes of anemia, what is classification of anemia, what are the investigations to do, and what is the treatment in detail about anemia. So let's start with the first slide. What is anemia? Okay, first of all, we will see what is anemia. Anemia is defined as reduction in the amount of hemoglobin and red blood cell mass in the blood. Either hemoglobin or red blood cells are decreased in blood below the normal range of the hemoglobin, that is called as anemia. The function of red blood cells is to deliver oxygen from the lungs to the tissues and carbon dioxide from tissues to the lungs. This is accomplished by the hemoglobin. In the red blood cells, there is a hemoglobin, a protein that useful for transmission of oxygen from the lungs to the tissues and transmission of carbon dioxide from tissues to the lungs. This is a very important function. Without this, a person can't be alive. Now, there is a WHO cutoff criteria for the anemia, means how the anemia is defined exactly by hemoglobin. Means for the woman, hemoglobin level should be more than 12 gram per dl. If the hemoglobin level for woman is less than 12 gram per dl, that is called as anemia. And for men, if the hemoglobin level is less than 13 gram per dl, that is also called as anemia. So this is the WHO cutoff of hemoglobin for the diagnosis or for the definition of anemia. Now, anemia is an extremely common disease affecting up to one third of the global population. In many cases, it is mild and asymptomatic and requires no management. The prevalence increases with the age and is more common in the women of reproductive age, pregnant women, and in the elderly. Anemia is very common disease. It is about one third of the world's global population that is having mild or the some degree of anemia, but each and every anemia is not require any treatment or any management, but the symptomatic anemia or the severe anemia or the significant anemia having hemoglobin level less than 10 or 11, that it requires the understanding and treatment. The anemia prevalence is more with increasing age, more in females and pregnant patients. Now, this is the normal red blood cell morphology. This is very important to know the normal red blood cell structure because it is important in finding some etiological classification of anemia. So here we will first see the shape of RBCs. The RBCs are disc shaped or donut shaped with a central indentation and a pale area. This is exactly structure of the RBCs. It is a disc shape. Size of RBCs is 6 to 8 micron meter in diameter. And what is the color? The normal morphology of the red blood cell shows a pale central area that represents one third of their diameter and the pinkish the peripheral area. The nucleus, RBCs do not have a nucleus, which allows them to change the shape and move around the body more easily. Because RBCs have to move all over the body through different organs, the shape of the RBCs should be changed at place to place. So, nucleus is absent in the RBCs. RBCs that deviate in size, shape, volume, structure, or the color are considered abnormal. This is why we are looking for the normal structure of the RBCs. Now, what are the abnormal red blood cell morphologies? These are various red blood cell structures, various abnormal RBC structures that are causes that is causative for the anemia, and that includes The spherocytes means spherical red blood cells, irregularly cells, microspherocytes, then elliptocytes means elliptical shape of the cells, ovulocytes means oval shaped cells, target cells, dacrocytes are there, stomatocytes are there, keratocytes are there. There are various types of red blood cell structures and that are individually responsible for the destruction of red blood cells and causing anemia. That also includes sickle cells, acanthocytes, and boat-shaped cells. These are variable red blood cell structures that will lead to the anemia. We will deal with all these structures in next slides. Now, first of all, come to the classification of anemia. Anemia is classified into two ways. First one is etiological classification and second one is morphological classification. We will see both of these one by one. First one is the etiological classification, means what are the causes or etiology that will lead to the anemia. This is a type of classification. Normally, the red blood cell mass represents the balance between the production and destruction of loss of red blood cells, means the production of red blood cells will be equal to the destruction of the red blood cells. When this balance get disturbed, anemia occurs. Means when the production of red blood cells will be less compared to the destruction of red blood cells, anemia will occur. Following are the primary causes of the anemia. By etiological classification, anemia is classified into three ways. First one is deficient or ineffective erythropoiesis, means decreased RBC production. Second one is excessive hemolysis, means excessive RBC destruction. And third one is the blood loss. Blood loss means be acute or chronic. All these are three etiological classifications of anemia. We will see all these one by one. First one is deficient or ineffective erythropoiesis, means the production of red blood cell is ineffective, not effectively red blood cells are produced. That means decreased RBC production. Ineffective erythropoiesis or decreased RBC production is a chronic condition that occurs when the bone marrow is active but unable to produce an adequate number of red blood cells. This means there is bone marrow is normal, but blood cells or the red blood cells are not produced effectively. This is the called as ineffective erythropoiesis. What are the causes of ineffective erythropoiesis? That includes folate deficiency, that is vitamin B9 deficiency, then iron deficiency, vitamin B12 deficiency, that is hydroxycobalamin deficiency, then lead poisoning and thalassemia. These are the certain causes where bone marrow is normal, but because of deficiency of these minerals or vitamins, the effective erythropoiesis is not working. Now, after first cause, the second cause is excessive hemolysis or the excessive RBC destruction. RBC destruction causes may be intrinsic or extrinsic. Intrinsic means within the red blood cell, there is some abnormality in red blood cell that will cause the RBC destruction. And extrinsically means there are certain abnormalities in the blood or outside the red blood cell that will cause destruction of RBCs. So, according to this, we have divided excessive hemolysis into two varieties, that is excessive hemolysis due to intrinsic red blood cell defect and second is extrinsically induced red blood cell abnormalities. We will see both of these in detail. First one we have seen is intrinsic red blood cell abnormalities that will lead to the excessive hemolysis. What are that conditions? That is, first one is defect in RBC membrane. In RBC membrane, if there is defect, that will lead to the RBC hemolysis. The examples are hereditary spherocytosis and hereditary elliptocytosis. What we have seen in earlier slides, that RBCs having different shapes like elliptocytosis, spherocytosis, acanthocytosis, teardrop cells that are prone for easy destruction. So the defect in RBC membrane like hereditary spherocytosis will lead to the excessive hemolysis. The second one is defect in hemoglobin production. Hemoglobin is a protein present in the RBCs, and if defective hemoglobin production, that will again lead to the hemolysis or the blood cell lysis. The examples of hemoglobin production defection is thalassemia and sickle cell anemia. The third condition is that affects RBC metabolism, like glucose 6 phosphate dehydrogenase deficiency and pyruvate kinase deficiency. These are two enzyme deficiency that will lead to the abnormal metabolism of red blood cells, that will lead to the hemolysis or excessive destruction of red blood cells. These are all causes, intrinsic causes means present inside the red blood cell, that may be in the red cell membrane, that may be in the hemoglobin, or that may be defect in RBC metabolism. These are the intrinsic causes of red blood cell destruction that will lead to the anemia. Second one is excessive hemolysis due to extrinsically induced red blood cell abnormality. Means the abnormality is outside the red blood cell. Okay, what are causes of that extrinsic causes of red blood cell destruction? First one is splenomegaly. In splenomegaly, there will be hypersplenism because all RBCs have to travel through the spleen, and if there is splenomegaly, there will be excessive destruction of red blood cells, and that will lead to the anemia. Certain infections, that is clostridial infections, malaria, Epstein-Barr virus, these are certain infections, and more other infections can cause excessive red cell destructions. This is extrinsic factor. This is, there is no abnormality in red blood cells, but extrinsic factors like splenomegaly infections are leading to the excessive destruction of the red blood cells. The third one is the mechanical injuries. Certain mechanical factors like cardiac wall diseases, hemolytic uremic syndromes, or thrombotic thrombocytopenic purpura. These are certain diseases or mechanical factors in the blood that will lead to the red blood cell destruction. Certain toxins or the drugs like ribavirin or the spider bite, these can also lead to the destruction of red blood cells. We have seen the extrinsic factors causing the red blood cell destruction, intrinsic factors, red blood cell destruction. Now we have come to the third part of the etiological classification of anemia, that is blood loss. Blood loss is very important part of the anemia. It can occur acutely or chronically. What are the acute causes of the blood loss? First one is the childbirth, means during delivery, there will be the huge blood loss. Second one is gastrointestinal bleeding. Sometimes the acute GI bleed or hemorrhoids can lead to the excessive blood loss. Some injuries, major injuries can cause acute blood loss, and surgery. These are all causes of acute blood loss. The second one is the chronic blood loss. There are certain chronic conditions that cause the small amount of blood loss for months or years that will lead to the anemia. That causes are bladder tumors, cancer or polyps in GI tract, heavy menstrual bleeding, kidney tumors, ulcer in the stomach or the small intestines. These are variety of causes that will lead to the chronic blood loss. Now we will come to the second variety of classification, that is morphologic classification. Morphologic means RBC structure. If RBCs are smaller size, larger size or normal size, even after that we are getting anemia, that is the morphological classification. First one class of the morphologic classification is microcytic hypochromic anemia. The second one is normocytic normochromic anemia, and third one is macrocytic anemia. We will see all in detail in next slide. First one is microcytic hypochromic. Microcytic means the red cell size is small. Micro means small size of red cells, and hypochromic means there is pigment. Chrome means pigment, and hypochromic means the pigment means hemoglobin, less amount of hemoglobin in the red cells. This is called as microcytic and hypochromic anemia. How this is seen in CBC? In complete blood count test or CBC test, we have to see for the MCV. MCV means means corpuscular volume. That will be less than 80 femtoliter. That will denote us that is patient is having microcytic hypochromic anemia. In the CBC report, we have to see first hemoglobin. If the less than 12, that means anemia is there. Then the second step is we have to look for MCV means mean corpuscular volume. That will be less than 80 femtoliter. That means there is microcytic hypochromic anemia present. What are causes of microcytic hypochromic anemia? First one is iron deficiency anemia. That is very important and most common cause of anemia. Second one is anemia of chronic disease. Third is sideroblastic anemia, then thalassemia and lead poisoning. These are the causes that will lead to the microcytic hypochromic anemia. Then second one is normocytic anemia. There is normal site of red blood cell is there. Means red blood cell has normal site, normal pigment, and if we will see the MCV will be between 80 to 100 femtoliter. Means normal level of MCV will be there. Still, that patient will be having hemoglobin less than 12. What are that causes? That causes are anemia of chronic disease, renal failure, aplastic anemia, pure red cell aplasia, myelofibrosis or myelophthisis, processes, multiple myeloma, and undernutrition. These are certain conditions that will lead to the normocytic normochromic anemia. Third variety of morphological classification of anemia is macrocytic anemia. Means RBC size is large, macrocytic. Macro means large size and cytic means cells. Large size of RBCs are there, still patient is having anemia. And if the large size of RBC is present, MCV in the CBC, if we see, that will be more than 100 femtoliter. So level of MCV will be increased. And what are the causes of macrocytic anemia? Folate and vitamin B12 deficiency is the most common cause. Then alcohol intake, liver diseases, hypothyroidism, myelodysplastic syndrome, chronic myelomonocytic leukemia. These are certain causes. Other than that, we have some drugs like diuretics, chemotherapeutic agents, hypoglycemic agents, and antiretroviral agents. These are certain drugs that can also lead to the macrocytic anemia. These are all micro morphological classifications of anemia that includes microcytic hypochromic anemia, normocytic normochromic anemia, and macrocytic anemia. And what is the etiological classification? Etiological classification is divided into three groups. First one is excessive RBC destruction, decrease RBC production, and third one is the blood loss. These are three etiologies or the causes that will lead to the anemia, and this second one morphological classification has three varieties, that is microcytic, normocytic, and macrocytic. This is two varieties of classification of anemia. Now, what are the clinical features of anemia? It is very important when some patient comes to you in OPD, and what are the clinical features will be there for that patient if he is having anemia. First one is the fatigue, feeling weak or tired, especially after exertion. This is very important. That is we call as easy fatigability, shortness of breath on exertion. Chest pain will be there if there is severe anemia. Otherwise, chest pain will not be there. Headache, lightheadedness, especially when standing up. Pale skin or the pallor will be present. Brittle nails, dry skin or hair. Iron is essential for healthy hair, skin, and nails. So these symptoms of the nail, hair, and skin will be there because of iron deficiency. Sore or inflamed tongue, mouth ulcers are there, abnormal or increased menstrual bleeding in females, loss of sexual desire, a common symptom in men, rapid heart rate, palpitations, and feeling of anxiety. These are all clinical features or symptoms of the patients when coming in our OPD or hospital with the severe anemia. Now, what are the investigations and workup for the diagnosis of anemia? For diagnosis on anemia, we should do various tests to find out the first of all diagnosis, and second, what are the causes of anemia. So we should do investigations one by one. First investigation is complete blood count. CBC is the very much important to do for each and every patient of anemia. In CBC, we have to see first hemoglobin. Hemoglobin will decide us that anemia is present or not. Second one is hematocrit. Hematocrit will say us that is percentage of red blood cells in blood. Means if there is hemodilution distribution or concentration of the blood. If hematocrit is increased, that means thick blood is there, hemoconcentration is there. If the hematocrit is less, that means hemodilution is there, patient is not dehydrated. Then after hemoglobin and hematocrit, we have to see for red blood cells, white blood cells and platelets. These are all important. Mean corpuscular volume should be seen at the last measure to see for average size of the red blood cells. As we have already seen, normal MCV level is 80 to 100 femtoliters. If it is more than 100 femtoliters, that means red cells are macrocytic, means macrocytes. And if it is less than 80 femtoliter, that means the red cells are microcytic. So this is the first investigation, complete blood count. In that we have to see all these parameters. The second parameter or the investigation is peripheral blood smear, a microscopic examination that tells about abnormal morphology of red blood cells or any abnormal cells. What is abnormal morphology? We have seen in previous slides, that is teardrop cells, spherocytes, elliptocytes, sickle cells. These are all causes for anemia. So each and every patient of anemia with CBC having low hemoglobin should undergo peripheral blood smear to see microscopic examination of red blood cells if there is any morphologic abnormality in red blood cell. So first CBC, second is PBS, peripheral blood smear. Third investigation is iron profile. Iron profile is very important. If the patient is having MCV or mean corpuscular volume less than 80, then we should do complete iron profile that includes serum iron, ferritin, transferrin saturation, and total iron binding capacity. These are all parameters comes into iron profile. The fourth investigation is reticulocyte count to see if bone marrow is working red blood cells at an accelerated rate. This is a sign of prior blood loss. Reticulocyte count is very important to find out if the bone marrow is properly working or not. If bone marrow is properly working, reticulocyte count is increasing and anemia is there, that means patient is having blood loss and bone marrow is hyperworking, means reticulocyte count is increasing, bone marrow is working more to compensate the blood loss. But if patient is having anemia, still his reticulocyte count is low, that means bone marrow is not working properly, or there is some raw material like iron or certain other nutrition that is deficient to make the red blood cells. That means the red cell deficiency or there is less production of the red blood cells. The fifth investigation is hemoglobin electrophoresis to evaluate the abnormal hemoglobin which is present in the thalassemia and sickle cell anemia. The hemoglobin electrophoresis is a very important investigation to look in all the patients of chronic anemia. Then sixth investigation is thyroid function test because hypothyroidism can suppress bone marrow activity which reduces red blood cell production and can lead to the anemia. Up to 60% of the people with hypothyroidism are diagnosed with anemia. So it is very important to do thyroid function test in all the patients of the anemia. The seventh test to do for each patient, for not each patient, but the test is coagulation screen that includes factor 5SA, fibrinogen level, prothrombin time, and international normalized ratio or INR. This is the investigation. This is not done in all the patients, but should be done in the patients related with the hypercoagulable state, for the hemolytic patients, or for the patients with the chronic liver disease. The eighth investigation is macrocytosis profile, means if MCB is more than 100 in the CBC and we are looking the red cells are macrocytic, then what are the investigations should be done? Macrocytic anemia can be caused by vitamin deficiencies such as folate or vitamin B12 or by other factors such as liver disease, alcohol abuse or hypothyroidism. So if we get macrocytosis or on peripheral blood smear, we should go for folate, vitamin B12 level, liver disease or liver function test. We should take a history of alcoholism, and we should send a sample for thyroid function test to know about hypothyroidism. Treatment for macrocytic anemia often involves correcting nutritional deficiencies with supplements or the foods. Now we will come to the last investigation to be done in the patient of anemia, that is liver function test. In liver function test, why it is important? Because for the patients with hemorrhage, bleeding especially in the gastrointestinal tract, it is a major cause of anemia in patients with chronic liver disease. Liver has a widespread connection with the anemia. In chronic liver disease, there will be the esophageal varices that will cause gastrointestinal bleeding and hemorrhage. So, in the patients of hemorrhage, we should do the liver function test. For the patients with iron deficiency, even for iron deficiency, the liver produces hepcidin, a hormone that regulates the iron absorption. So we should see the liver function. If it is normal, that means it is producing normal amount of hepcidin. That means the iron absorption will be normal. So liver function will be done in each and every patients of the anemia. Then hemolysis. This is a common cause of anemia in patients with the liver disease, particularly those of alcoholic liver disease. So in patients with alcoholic liver disease, there might be hemolysis that will cause anemia. Certain nutritional deficiencies, when the liver is compromised, it can be more difficult to absorb nutrients from the blood, which can lead to the nutritional deficiencies and anemia. So in nutritional deficiencies also, liver function test is very important. And in the last, liver cancer, anemia can be an early sign of liver cancer. So there are variety of diseases that can lead to the anemia, and these diseases are related to the liver. So each and every patient of the anemia should have to evaluate for liver function test. Now, facts about to be considered while investigating anemia patient. We have seen about 9 type of investigations to be done for the patients with anemia, but all are important to do for each and every patients of anemia? No. The answer is no. All investigations should not be done for each and every patients of the anemia, and most patients of don't need extensive testing. All tests are not required for the every patient. The specific test order will depend on patient symptoms, health history, and the result of the CBC. First of all, we have to do CBC. We have to do complete physical examination of the patient, and we have to take the complete thorough history of the patient. And thereafter only, according to the examination, according to the history, and according to the CBC report, we have to do certain required investigations. So all investigations are not necessary to do for all patients of anemia. Now come to the treatment part of the anemia. Till now we have seen the definition of anemia, cutoff criteria of anemia, what is etiological classification of anemia, what is morphological classification of anemia, and symptoms or the clinical presentation of anemia, and what investigation we should do for anemia patient. Now come to the last part of the anemia, that is treatment of anemia. What we are having multiple options to treat the anemia according to the etiology or the cause of the anemia. First one is the iron supplement. Iron supplement can be given by oral and parenteral route. First of all, we will see oral iron supplement. In the asymptomatic patients with established iron deficiency anemia and an intact gastrointestinal tract, treatment with oral iron is usually adequate. For the patient, we have seen CBC, we have less MCV, then we did iron profile. We know there is iron deficiency anemia. If the patient is not having any GI bleed, he is able to tolerate oral iron, then the oral iron supplement is the best therapy for that patient. Ideally, oral iron preparations should be taken on an empty stomach since food may inhibit iron absorption. So keep in mind that to suggest for the patient that iron should be taken on empty stomach. Typically, for iron replacement, therapy up to 200 milligram of elemental iron per day is given. If we are giving oral iron supplement, keep in mind that we should give sufficient amount of iron, that is 200 milligram of elemental iron per day. This is a adequate amount of iron supplement. Out of 200 milligram of elemental iron given to the patient, up to 50 milligram of iron should be absorbed by the intestine of the patient. This is the normal iron supplement and its use. Iron supplement increases a red blood cell production by 2 to 3 times normal in an individual with normally functioning marrow and appropriate erythropoietin level. If the patient's bone marrow is normal, erythropoietin level is normal, and we have given iron supplement, that will increase red cell production by 2 to 3 times. The goal of therapy in individuals with iron deficiency anemia is not only to repair the anemia but also to provide store of at least 0.5 to 1 gram of iron. Means if we have some patient with iron deficiency anemia, and first of all we have to calculate how much iron deficiency is there, and after that we will not only supplement the required iron deficiency but also we also give some store amount of iron, that is half to 1 gram of iron extra more than the iron requirement of or iron deficiency of that patient. Sustained treatment for a period of 6 to 12 months after correction of the anemia will be necessary to achieve iron store. Oral iron preparations are ferrous sulfate, ferrous gluconate, ferrous fumarate, ferrous ascorbate. These are the tablet forms of the iron that can be given as oral iron supplement. Encouraging dietary intake of the iron-rich food is recommended for the patients of iron deficiency anemia. Not only tablets or the oral supplements, we should encourage the patient to take diet rich in the iron. Okay, we have seen these all tablets, that is ferrous sulfate, gluconate, fumarate, and ascorbate. These are all tablets, and we know that we should give a daily dose of 200 milligram of elemental iron for all the patients. Now, if we have given oral iron therapy, what are the complications of that oral iron therapy? There are many side effects of the complication of oral iron therapy that includes gastrointestinal distress is the most prominent and is seen in at least 15 to 20% of the patients. The abdominal pain, nausea, vomiting, and constipation. These are the many other complications or the side effects or the adverse effects of the iron therapy. Some tips for taking oral iron supplement. For effective oral iron working, we should have some tips that includes when to take iron tablets. When to take iron at least 30 minutes before a meal or 2 hours before other medications. We should not take iron tablet with other medication, or it should be take at least 30 minutes before meal. Second one is what should be avoided with iron tablets. Avoid taking iron with milk, calcium, antacids, high fiber foods, or caffeine. These are certain foods or the products that should be avoided to take with iron. How to improve oral iron absorption? Some studies suggest taking iron with orange juice or with vitamin C supplementation is increase the efficacy or the efficiency of iron supplementation. So these are the three things should be kept in mind or to suggest the patient while giving oral iron therapy. Then come to the parenteral iron therapy. After oral iron therapy, now we have to come for the parenteral iron therapy. Intravenous iron is given to the patients who are unable to tolerate oral iron or who needs iron on regular basis, usually due to persistent gastrointestinal or menstrual blood loss. This is the only indication for intravenous iron. Otherwise, whoever tolerating oral iron, give oral iron therapy. The safety of parenteral iron has been a concern, largely driven by the high adverse reaction rate to high molecular weight iron dextran. Because in the past there were high adverse drug event reactions rate was there in the past. but the newer parenteral iron preparations have much lower rates of the adverse effects. Because of the many adverse events or the effects in the past, the use of parental iron was variable, but in the newer parental iron preparations are there with the very low adverse drug effects. Now we will see the formula for iron supplement. How much iron will be given to the patient? It will not be given blindly to each and every patient. We should calculate the iron deficiency in that patient, and then only we should give that much required iron supplement to that patient. How the iron requirement is calculated? The formula is patient's body weight in kg multiplied by 2.3 multiplied by 15 minus patient's hemoglobin, means how much hemoglobin of the patient. This is a formula, and what will be the calculation comes that plus 500 to 1000 milligram of the iron that will be required for the storage. So this is the total amount of iron replacement of the patient. What are the dose of parenteral iron preparations? We have seen the oral iron supplements that include ferrous ascorbate, ferrous fumarate, ferrous, and this is the parenteral iron therapy that includes ferromoxitol, ferrigluconate, LMW iron dextran, ferric carboxy maltose, ferric dairies maltose, iron sucrose. These are all the different preparations of parenteral iron with the different milligrams of doses. In one dose or one day, we can give ferrigluconate of 125 milligram per infusion, means for one day we can give it only for 125 milligram. For ferric carboxymaltose we can give 750 milligram per infusion or the per day. So these are the different varieties of the infusions for parenteral iron preparations. And first of all, we have to calculate the iron deficiency, and accordingly we have to give these all doses for required duration. Now, what are the complications of penicillin therapy? Same as like oral iron therapy, there are many other complications of parenteral iron therapy that includes anaphylaxis. It was very much common in the past, but now it is much rare with the newer preparations. Arthralgia, skin rashes, and low-grade fever. These are certain complications of parenteral iron therapy. First one we have seen for the treatment of anemia, that is iron therapy. Second one is the vitamin B12 supplements. It is usually necessary to treat the patients who have developed cobalamin deficiency with lifelong regular cobalamin supplementation. If some patient has a cobalamin deficiency in his blood, then we should treat that patient with lifelong regular cobalamin supplementation. The indications for starting cobalamin therapy are a well-documented megaloblastic anemia or other hematologic abnormalities and neuropathy due to deficiency. Replenishment of body store should be complete with 1000 microgram intramuscular injections of hydroxycobalamin given at 3 to 7 day intervals. This is the normal dose for vitamin B12 supplementation. For maintenance therapy, 1000 microgram hydroxycobalamin intramuscular once every 1 to 3 months is satisfactory. This is the exactly dose for the vitamin B12 supplementation, and for oral supplementation which we can give tablet hydroxycobalamin 1500 microgram once daily, and that's to be continued for complete replenishment or complete supplementation. Now we have seen the second treatment, that is B12 supplementation. Now we have come third option, folic acid supplements. Oral doses of 5 to 15 milligram, usually 5 milligram is used of folic acid daily as satisfactory. It is customary to continue therapy for about 4 months when all the folate deficient red blood cells have been eliminated and replaced with the new folate replete population. We should give 5 milligram of the folic acid for 4 months. This is the normal course. Till that time, all the RBCs will be folic acid rich. Before large doses of folic acid are given, cobalamin deficiency must be excluded and if present, corrected Otherwise, cobalamin neuropathy may develop. If some patient is having cobalamin deficiency and we are supplementing only with the folic acid, that patient will develop neuropathy. So, we should correct first cobalamin deficiency with vitamin B12, the dose we have discussed in last slide, previous slide, and thereafter only we should give folic acid supplementation. The fourth treatment option for the anemia is blood transfusion. It is not given for the all patients. It is given only in the emergency or when there is severe anemia. Rather than blood transfusion, treating underlying cause of anemia is more important. For example, if anemia is caused by deficiencies in iron, vitamin B12 or folate, their supplement or the balanced diet may be enough to restore healthy red blood cell production. So each and every patient of anemia will not require any blood transfusion. Blood transfusion is reserved for the individuals who have symptoms of severe anemia like shortness of breath, e.g., fatigability, or have cardiovascular instability, continued excessive blood loss, and who requires immediate intervention. These are the patients who have severe anemia and symptoms of anemia that are the candidate for the blood transfusion. The fifth option for the treatment of anemia is erythropoietin. Erythropoietin stimulates the bone marrow to produce more red blood cells. Erythropoiesis means the production of red blood cells, and erythropoietin is the injection that will to produce more red blood cells. Useful to treat anemia caused by chronic kidney disease, chemotherapy, or critical illnesses. Dose is 50 to 100 units per kg. It is given intravenously or subcutaneously, and the usual dose is 4,000 units given subcutaneously thrice weekly, 3 times weekly. Because it is given mostly by the patients by himself in the home, so it is given subcutaneously, and the dose is 4,000 units 3 times weekly. Side effects are the pain at the injection site, swelling, high blood pressure, fever, nausea, and dizziness. These are certain side effects of erythropoietin injection. The sixth option is the bone marrow transplant. A bone marrow transplant, also known as the stem cell transplant, is the option for severe cases of aplastic anemia, a condition in which the bone marrow doesn't produce enough red blood cells. If the patient is having all the nutrients like vitamin B12, folic acid, iron in the body, but the bone marrow is not working like as in aplastic anemia, the treatment option for that patient is bone marrow transplant. A bone marrow transplant can be potentially curative treatment for aplastic anemia, significantly improving the patient's quality of life and survival rate. The transplant process is intensive and can cause serious complications. There are also complications of bone marrow transplant. You are looking that each and every procedure or the each and every treatment of anemia is having its own complications or side effects. So bone marrow transplant has complications like infections, sterility, temporary hair loss, transplant rejections. These are very serious side effects of bone marrow transplant. The next option of treatment for the anemia is dietary changes. Eating iron-rich food and foods that contain vitamin B12 are the diets that are important for the patient with anemia. This is the home education for the patient to how to take a food containing the vitamin B12 and the iron that is required for the correction of anemia. The vegetables like dark green leafy vegetables like spinach, collard green, broccoli, string beans, these are the certain vegetables that increase the blood hemoglobin level. Certain fruits like strawberries, watermelon, figs, dates, raisins, dried apricots, prunes, these are certain foods. Pulses like beans, peas, lentils, chickpeas, tofu, these are certain pulses. Then nuts and seeds like pumpkin seeds, sunflower seeds. Then meat and seafoods like chicken, beef, pork, liver oysters. Then fish that includes perch, halibut, swordfish, bluefish, and other foods like eggs, wheat products, oat cereals, rye bread, enriched rice, These are certain vegetable, fruit, pulses, meats that are very important, or the diet including these certain products is very important for the patient with anemia. So while counseling for the patient of diet, these all ingredients should be included in his diet. This is all about very important topic anemia. We have seen all the important aspects of the anemia, including definition, cutoff diagnostic criteria of anemia, then what is etiological classification, then morphological classification, then what are the investigations to be done in the anemia, then what are the clinical features of the anemic patient, and in the last we have seen the treatment of the anemia. In the treatment of anemia, we have seen first is oral iron supplement, then parenteral iron supplement, then vitamin B12 supplement, then folic acid supplement, then we have seen erythropoietin therapy, then we have seen the bone marrow transplant and dietary changes or dietary supplement of iron and vitamin B12 rich products. So this is all about the anemia. We will stop here. We will meet in next lecture with new topic. Till then, thank you.